Good morning, everyone. Thank you so much for joining us for the next edition of SAB's Bronchoscopy Blitz. My name is Jonathan Kurman. I'm an interventional pulmonologist in Milwaukee, Wisconsin. I want to thank Medtronic for sponsoring our webinar today. Today's presentation is entitled Precision in Practice, Harnessing the Power of Fluoroscopic Navigation to Build a Sustainable Lung Biopsy Program. Here are my disclosures. The only one that is relevant for today is that I am both a consultant and speaker for Medtronic. So I just want to set the stage a little bit. We all know this, but it's good to review so that we understand the gravity of the situation. Lung cancer is the #1 cause of cancer-related deaths in the United States. Over 20% of cancer deaths are related to lung cancer, and it kills more people each year than breast, prostate, and pancreatic cancer combined. In 2022, which is the last year for which we have data, there were almost 250,000 new lung cancer cases. Prior to 2015, in the US, we were identifying about 150,000 lung nodules per year, and that number has increased exponentially since then to where we are now identifying over 1.6 million new lung nodules each year in the US. We're finding lung nodules on about 30% of all CT scans that are done. My prediction is that this number is only going to increase in the future. Recently, the USPS TF guidelines for lung cancer screening were updated. They expanded the age for eligibility and decreased PAC year history. CMS guidelines do not reflect those updates yet, but if they do incorporate them into the future, we're going to see much more lung cancer screening taking place, which will likely translate into many more pulmonary nodules being identified. Guidelines recommend that when you have a pulmonary nodule that requires a tissue diagnosis, that you utilize a minimally invasive strategy to biopsy the pulmonary nodule, so that we're not doing diagnostic surgeries. The term superdimensioned has been used for years and years to describe a technology that has evolved over time. Prior to version 7.2, there was no fluoroscopic navigation. With version 7.2, fluoroscopic navigation was incorporated, but the name didn't change. It was still superdimension, albeit with a new version number. After 7.2, the ILLUMISITE platform was introduced, and this represented a dramatic change from the prior superdimension system, in that it incorporated both fluoroscopic navigation as well as continuous guidance. These two features are very important because of CT to body divergence and the negative impact that can have on pulmonary nodule biopsies. Where your nodule is preoperatively is very different than where the nodule is intraoperatively, and that's what you're seeing here in this video. When someone is under anesthesia for a procedure, their lung position is different than when they had their preoperative CT scan. So that green ball, which is the virtual target, is not necessarily representative of where the nodule is intraoperatively. And this is for a variety of different reasons. There's differences in lung volumes between a full inhalation, like what you do when you are getting a CT scan, versus the tidal breathing you are under during the procedure. atelectasis that inevitably develops even with a robust anesthesia protocol. If someone is under anesthesia, they have chest wall muscle changes. There are other anatomic changes as well, typically from the instruments that are being used. And then patient position, even something like the use of a pillow can impact where the nodule is. The ILLUMISITE platform really does a nice job helping you to correct for the CT to body divergence because it introduces something called local registration. Local registration is optional. It's done after the initial registration, and it's performed for each peripheral target, but it has the ability to correct for divergence up to 3 centimeters. And particularly in the lower lobes where divergence can be on average 2.5 centimeters, this is critical. So here's the local registration workflow. As I mentioned, you perform your initial patient registration, and then you simply navigate the catheter to within 2.5 centimeters of the virtual target. You don't have to be right on it. In fact, I would discourage you from trying to optimize your catheter position to the virtual target here, because again, that virtual target is not where the nodule actually is. Then you're going to do a 50-degree rotation with the C-arm, and that is going to capture 2D fluoroscopic images, which are then processed into a 3D volume. You're going to mark your navigation catheter and your target, and then the system is going to use those marked locations to align the CT data to the peripheral airways that are near the target, and then you can update the position of the navigation catheter on the screen and then proceed with your biopsies. While you are biopsying, even after you remove the locatable guide, you're going to be able to see exactly where your catheter tip is because of sensors embedded in that catheter tip. So you're going to be able to maintain alignment with the target even after your locatable guide is removed. And this is going to give you continuous guidance even while you're taking biopsies. One of the recent advancements in the ILLUMISITE platform, which is continuing to be upgraded frequently, is the improved compatibility with digital fluoroscopes. These are some of the different digital options that are compatible now with the ILLUMISITE platform. As you can see, there's a range of different options, all from different manufacturers, making it imaging agnostic. So now let's transition into the data. When digital tomosynthesis was introduced with version 7.2, it resulted in a significant increase in diagnostic yield and target overlap compared to when we were not using local registration. The first figure here is from a prospective 2-center study that assessed the localization accuracy of fluoroscopic navigation. And you can see that before local registration and location correction were utilized, there was only about a 68% overlap between the virtual target and the actual target. But when you incorporated input from digital tomosynthesis and subsequent adjustment of the catheter position, you were able to achieve overlap in 95% of cases. And what does this mean? This means that when you biopsy the green ball, you're going to actually be biopsying the intended target, the actual nodule. And then there was another retrospective single center study that actually looked at diagnostic yield going from version 7.1 without fluoroscopic navigation to version 7.2, and they saw their diagnostic yield jump significantly from 54% to 79%. Now, how does this change once you incorporate the ILLUMISITE platform into the equation? Well, here you're going to go up even more. You're going to take your 79% overall diagnostic yield and increase that to about 83% in this prospective single center study. And then when you compare ILLUMISITE to to an older version of the super dimension system. In this retrospective single center study, they went from 74% all the way up to 87%. So again, tremendous advancements in diagnostic yield, going up and approaching the level of a transthoracic needle aspiration. These data are from my site. I worked on this with Cameron Gamelin and my former partner, Brian Ben. And we looked at our results using the ILLUMISITE system for about the first year and a half or so that we had it. And we biopsied about 160 nodules during this time. The average nodule size was just over 2 centimeters. Most did not have a bronchus sign, and we had a diagnostic yield of about 84%. And this only decreased slightly in the bronchus sign negative group. This was a pivotal study that came out a few years ago, actually a little over a year ago, in chest, and this compared head-to-head the Super Dimension system version 7.2 with fluoroscopic navigation versus the ion robotic system. The primary endpoint was diagnostic yield, and they showed 80% for the Super Dimension system and 77% for ion, and that's what you see highlighted in the graph at the bottom there. Secondary endpoints were complications, which were low for both systems, and overall they were able to conclude that there was no improvement in diagnostic yield when using a robotic assisted platform within the first 6 months of use by the same operators targeting similar lesions in similar patient populations. Each year in the US, we're performing almost 200,000 transthoracic needle biopsies. And this was a retrospective cohort analysis using an administrative claims database from a large US commercial health plan. They looked at almost 17,000 patients who underwent a transthoracic needle biopsy. They found a complication rate of 25% within 3 days of the procedure. The most common complication was pneumothorax, and almost a third of those patients required chest tube insertion. And a complication was more likely if a biopsy was being done on an inpatient, if they had a prior diagnosis of COPD or had a previous bronchoscopy. In general, electromagnetic navigational bronchoscopy has a lower reported complication rate and a higher potential contribution margin compared to transthoracic needle aspiration. When you look at the data that are out there, there are about 4 times fewer significant patient complications with electromagnetic navigational bronchoscopy as opposed to transthoracic needle aspiration, and an over 200% higher contribution margin on average here. And from a patient standpoint, you're able to both diagnose a cancer and stage someone with a bronchoscopic approach as opposed to a transthoracic needle approach. So when you look at the variable complication rates, particularly the pneumothorax requiring a chest tube, and you look at the 7.3% versus 2% for TTNA and ENB respectively, and assuming that the cost with a chest tube is the same, when you look at the cost per 100 biopsies, you can get an average potential cost savings of almost $60,000 for every 100 biopsies you do. And that's not an inconsequential number. This is an interesting analysis that we did, comparing the fixed costs among navigational platforms. This does not factor in any of the reusable or disposable component. And these are estimated market data from 65 hospital members over the past 12 months in a voluntary database. And the data includes both high and low range for the list price and the quote price. The chart here importantly shows the average quote price as well as the average annual fee. So again, 65 centers, reported data, and you can see the electromagnetic navigational bronchoscopy option all the way on the left at about 250 or so thousand. And then you can see dramatically higher costs for robotic assisted bronchoscopy systems 1, 2, and 3. And then when you also go all the way to the right hand side, you'll see the mobile cone beam CT option. Here again, just the capital is more expensive than the electromagnetic navigational bronchoscopy option overall. And so when you're thinking about value, it's important to really crunch the numbers. And one of the things that can be helpful is a cost of ownership calculator, in which you can estimate acquisition costs, utilization costs, and operational costs. And all three of these categories factor into how much a particular system is going to cost you and your hospital and how much value you're going to get for that. In order to make something like this effective, you need to have transparent pricing, and then you can compare the cost of the different platforms most accurately. This is just an example of some of the different capital costs associated with different systems. You also have utilization costs as well. There are more utilization costs for the robotic systems as opposed to the electromagnetic navigational platform like ILLUMISITE. And then you have operational costs as well. And if you want, you can even keep the reprocessing costs the same, even though they are likely divergent. So when we think about practice development, we can think about it in terms of a few different categories. First, let's go over training and education for physicians and staff. So under training and education, it's really important to realize that formal training is the key to success here. If you can learn to leverage the ILLUMISITE technology to its full potential, there are going to be very, very few nodules that are inaccessible. It won't matter if they are peripheral. It won't matter if they are sub-centimeter. Harnessing the technology is key. And one of the most important things with the ILLUMISITE platform, which is different than prior iterations of the superdimension system, is that everyone has a workflow that is a little bit different. So your anesthesia team is going to have one workflow. Your radiology team is going to have one workflow, and everybody needs to know their responsibility and their task, so that way it'll result in the most efficient case possible. In terms of the equipment, there are different catheter angles that are available, as well as different biopsy tools, and you can leverage these relationships so that you can really access any nodule anywhere in the lung. ILLUMISITE is a completely new platform, but the workflows in general are similar to prior versions of superdimension. So if you've used any of those in the past, you're not going to have a significant learning curve getting up to speed. Usually maybe 5 cases or so before you become independent and generally pretty proficient on the system. Marking the target accurately here is very, very important, but we're not as reliant upon the delineated path on the virtual bronchoscopy as we were previously. Because remember, you just have to get within 2.5 centimeters of the virtual target in order to launch local registration. And that's gonna tell you where your target actually is, and then you can go biopsy it. So when you biopsy the green ball now, you will actually get the result. And then in terms of anesthesia and radiology, as I said before, they have particular workflows. Once you have gone over workflows with those groups a couple of times, they'll be in sync with you, and everything in the procedure will just flow very nicely. In terms of integrating the ILLUMISITE platform into the existing practice workflows, just remember you're using the same C-arm, you're positioning the ILLUMISITE tower in the same place, you're using the same scope holder. Really, the additional steps are for the radiology tech and for the anesthesia provider, but they're doing the same thing every time, so efficiency rapidly improves here. Now that I've become efficient with this platform, my typical case duration from doing the airway exam to being done with the ILLUMISITE platform and transitioning onto my EBUS procedure is about 25 minutes or so. One of the things that ILLUMISITE can help you accomplish is really becoming more collaborative with your thoracic oncology team. And what that will allow for is converting some of those transthoracic needle aspirations into ILLUMISITE guided biopsies. And you can really help facilitate this by highlighting your capabilities during multidisciplinary meetings, i.e. tumor boards. If you present exemplary cases that really demonstrate what ILLUMISITE is capable of, you're going to have more biopsies sent your way. And you can also help dispel some of the preconceived notions about maybe not being able to access nodules in the periphery or those without a bronchosign, which are still fairly pervasive. As you educate those around you in your multidisciplinary team, your referral volumes will increase over time, and patients are going to really benefit because they're going to have one anesthetic episode, but they're going to accomplish two things, both a diagnosis and staging. When you want to grow your practice, it's important to leverage your marketing teams and other patient education strategies. This is an active process. It can't really be passive, but once you do it, you're going to see referrals start to flow in. And you want to make it easy for referring providers by eliminating any barriers. Go out and meet your referring providers. Make sure that your radiologists who are doing the CT guided biopsies know who you are. And this can really help facilitate a bidirectional patient flow, because you're going to get some referrals that are better suited for a transthoracic needle aspiration, and you can send those their way, and vice versa. I'm going to echo this one more time, but within a particular area or within a particular institution, culture shifts take time, but they are worth it when it leads to improved patient care. This is my ILLUMISITE procedure workflow, and it's pretty detailed, but if you adopt something similar to this, then you're going to increase your efficiency over time by having a standardized approach, and you'll be able to get the best yield from the system. Just to highlight a few different aspects, you want to try to pre-oxygenate with a lower FiO2 to decrease resorption atelectasis. Use a larger ET tube if possible. As soon as the bronchodapter goes on, decrease your FiO2 to the lowest tolerable, increase your PEEP, and do some recruitment maneuvers in order to prevent atelectasis. Your registration should be pretty quick, should take around 30 seconds or so, and then you are navigating to your target and remember, just get within 2.5 centimeters of it, put the scope holder on, bring in your C-arm, go through the local registration workflow, do your C-arm sweep, reposition the catheter, and then start biopsying. When you're biopsying, think about running 2 tools at one time. That way, you're never just standing around waiting. Somebody's always doing something. As I mentioned before, ILLUMISITE is continuing to upgrade their platform. The latest upgrade, which just came out a month or 2 ago, provides instant access to procedural recordings. I love this because I can go back and look at my cases. I can teach my residents, teach my fellows, and get material for presentations. And you don't have to go through the company or the rep. It's just right there for you after the case. And then the other newest feature is the ability to replace the extended working channel mid-procedure. So if you want a different angle, you can get that without having to repeat registration. So in summary, if you can harness the power of fluoroscopic navigation and the ILLUMISITE platform, you can really build a sustainable lung biopsy program. Just remember, your navigational platform is going to have a lower complication rate and a higher potential margin than a transthoracic needle aspiration. And the ILLUMISITE platform is going to make your life easier by providing continuous guidance of where the catheter tip is and local registration, so that when you get to the green ball, you know you are biopsying the actual target. As I mentioned before, cultural shifts take time, but they are worth it in the end when it leads to improved patient care. I want to thank everyone very much for listening today. Once again, my name is Jonathan Kurman, and I want to thank both Medtronic and the SAB for today's webinar. Thank you very much. Have a great day, everyone.